I'm Dr. Stephanie Nixon. I'm a speech language pathologist. I'm here to talk to you about words have weight again. This is part 2. Okay, providers, so before you type a single subjective adjective into a patient's chart, ask yourself one critical question. Can I defend this word in a liability case? Is it a word that you can objectively prove? What you put in the chart for your patient is a legal record of findings, reasoning, and function. It is not a wastebasket for your personal assumptions. When you prioritize narrative shorthand over data, you create a medico-legal risk and pass a biased cognitive filter down the line to every provider who follows you, particularly if you're in a large health system. You are merely adding another messy post to a deranged Twitter feed, as noted by a patient in a study by Sloan and colleagues. So let's take a real emergency department event. You've got a patient, they're sitting there, they're seeing gray when they stand up, they're kind of curling down, and you get one BP that looks fine, 128/87. But that was actually in the ambulance on the way to the hospital. As time has gone on, this patient is reporting that they are dehydrated, their lips are peeling, and they're seeing gray when they stand up. There were 2 other BPs they're trying to tell you about that were taken when they arrived at the hospital that were low, that set off alarms. They mentioned to you they have dysautonomia. In this emergency department event, a provider charted that there was a histrionic component to the patient's presentation. To maintain that subjective narrative, the provider highlighted the BP obtained in the ambulance that didn't match the patient's symptoms. Later in the text of the note, they mentioned acute hypotensive episode with a blood pressure of 80/51, along with elevated white blood cell count of 14.3 K, 84.4% neutrophils, 8.3% lymphocytes, and many other abnormal labs, along with accelerated junctional rhythm on an EKG. But this information is predominantly highlighted in the tables. The recent chest CT 7 days prior explicitly documented tree and bud nodularity. The patient was being evaluated for bronchiectasis and mycobacterium, among other bacterial lung infections. This is one example of how providers cause clinician associated trauma. The cumulative psychological harm from repeated medical gaslighting and biased charting. Worse, precision errors can ruin a provider's credibility. A few weeks before that ER event, a resident misidentified the patient, which was me, as Ms. Dixon. Regardless of forgetting my formal title of Dr. Nixon, they used the wrong last name. The attending physician, who knew me, rubber stamped that note anyways. Under the Cures Act, patients can see a provider's notes in your signed attestations instantly. If you miss a name or an error in a name, the patient in the law can always assume you rushed the clinical review. So let's pass the mirror test and raise your standard of data stewardship. Audit your adjectives. Stop using performance words like claims, dramatic. Investigate patients' baselines. Don't pathologize fast communication or speech rate as manic or anxious without checking for neurodivergent baselines like ADHD. And if you don't understand it, or if you didn't ask, again, think about how that can affect that patient the next time. In health situations, there are real reasons patients might be anxious. It doesn't mean they're exaggerating. Understand what they're bringing in. If a patient walks into your office with 30 pages of hand-typed notes, it might be an executive functioning tool to manage stress and not health anxiety. I understand that can feel overwhelming to you as a provider. I get it. Perhaps they don't want to blink. Perhaps they've been the patient sitting there in an appointment in which a provider says, "Why didn't you tell me that?" "I'm sorry, I forgot." Also, you can use an honest pivot. If you are totally out of spoons yourself as a provider, which does happen, and capacity, don't just rush a diagnostic label. Try radical honesty. My capacity is low right now, and I want to give your data the deep thought it deserves. Let me review your records this week and follow up with a telehealth visit in a few days. If you don't have time in 10 days, figure out a way to get a phone call in. Have a resident do it. I don't know, but anything except dismiss this patient. Be the clinical partner and protect your practice, and be the provider who keeps those dominoes standing. Follow the link to my blog for all the details.